Hi, John.
Hey, Abby, how you doing?
I'm fine.
Working hard?
Yeah, working hard. Running around, working hard.
Man, oh man, I had the China webcast scheduled with Ben at 8 this morning, a couple hours ago.
Uh-huh.
And I didn't think it was going to happen because I really didn't hear back from the people of Sufinov in
Yeah.
Russia.
Yeah.
And the time came, and I heard from someone that says, "Aren't you going to do the China webcast?" I thought to myself, I haven't arranged anything, but luckily we pulled it off.
Oh, okay. So you did have the webinar, huh?
Yeah, we did have it. We did have it, but it wasn't
king has
really
joined.
promoted. It wasn't promoted well.
The king has joined, John.
Yeah, he's here. I know. I can't bow today. I have a bad back. We just changed here. Yeah, I got news for the king. They mentioned him in Boston.
Yeah.
We televised that conference from Harvard. I mean, not from Al Mefti's Brigham Women's. It's called Brigham's actually in Boston.
Yeah.
Good day. The king is here. Can you hear me? Yes, no, his audio is not on. I think your microphone is not working, Atul. Okay, you're connected now. Can you hear now?
John, there is some, I'm working on a new computer.
Oh, I got it. I got it.
I'm not sure if I will be able to work. There is no share button on my screen. John, what should I do?
No share button. Are you using a different computer?
Yeah, I am using different computer.
Okay, well, you have it downloaded, right? It looks different than normal, right?
It is looking a little different. Should I use my old laptop? Then it may not be as good.
No, you can try to reinstall Zoom. It's real fast. Okay, let me give you the address here.
So log out and log in again.
Yeah, log out, log in. Yeah, we could try that before downloading. Why don't you try that, Atul? Log out and log in again.
No, John, what I'll do is, this looks very difficult to me. Should I just use the old laptop kind of thing?
Or re-download Zoom. It'll be on let me give you the link for that. Okay.
Yeah. No.
Yeah, zoom.us/download.
I should copy this, and what I should do with this?
Yeah, reinstall it and then reboot. Install it and then reboot. So just get off this, click on that link, okay? Get off this Zoom and go download that.
I don't know, John, what to do now.
Yeah, just get off this computer. Get off it completely.
Can you just note down? Just a minute, John. Just a minute, my friend. I have
We got time. We got plenty of time.
Okay, so I should leave from here, right?
Leave from here and go to that link and download the new Zoom.
Okay.
I'm glad the king can obey orders.
He's obeying your orders, John, nobody else's. So are we all set for tomorrow?
Yeah, it sounds exciting.
So what we're going to do is, day 1 is from Lilavati Hospital. Day 2 is from the Somai Hospital. Okay. So we have
You guys are
about
sneaky. You snuck that second day in. Because it's nighttime here,
okay. So we'll
But
see how
that's
it goes.
okay.
We'll see how it goes.
Yeah, let's do the first one and see how it goes, okay?
Okay. Then you
Yeah,
tell me. What we can do is, if we once you join in, you can make the hospital as a co-host. Like tomorrow, it will be easy. So someone in the hospital will be there, make them co-host, and then you can. And once we have a couple of panelists, and tomorrow I will be on the panel also, so it is going to be
yeah,
a little easy for you. For
yeah, we'll
some,
be communicating. We'll be communicating.
yeah,
I
we'll
may say,
communicate. Yeah,
I
so
may
that you
say I'm
can.
going to bed.
Yeah,
But yeah, it's no problem making you co-host.
yeah. So the second day I will not be co-host, but we'll get someone to be co-host. Second day I will be washed up. The first day I can be co-host.
We'll probably do it, but
Okay.
we need panelists. I mean,
Yeah, we've told. Yeah,
to watch a screen with just someone operating it, it's not going to be very productive for the viewer.
yeah,
Not completely, not all the time, but in a timely fashion, so
yeah.
that they're engaged, they're really watching, and they're making relevant comments to what
Yeah.
what's the tool's doing. That's important.
Yeah,
We
we'll
get
do that.
good
We'll do that,
supporting
John.
cast.
Yeah, yeah,
I think a lot of neurosurgeons would love to do that if you need to
yeah.
get someone to do that. I'm sure there's lots of Atul fans. No,
No,
they
we've
don't have to
told.
stay there the whole time, just like an hour or whatever.
So we've told a few people. Dr. Arshad Parekh is going to be there. So I think we'll be able to do it. And we have these Dr. Marcos from Brazil. He's actually visiting us. So he's also going to be
Dr.
there.
Jacques Marcos is visiting you?
Yeah, Dr. Marcos Wagner. I don't know if you know him. I sent you his name.
Okay, can you send it again? Can you put it in the chat here? I missed it.
Okay, I'll send it back to you on WhatsApp, the list of panelists.
Yeah, back up, yeah, maybe, okay, I'll check, maybe it's on WhatsApp.
Yeah, no, it is there, but I'll just forward it again to you.
Oh, yeah, I see your WhatsApp. Oh, Dr. Marcos.
Yeah.
Oh, really?
So, yeah. He's visiting us. So he will be there in the OR too. So maybe he can be, coordinating stuff
yeah,
with you.
he's from Brazil.
Yes.
Yeah, I televised a webcast for him. Yeah, I know who he is. So he's
Okay, great.
visiting you in Mumbai.
Yeah.
Oh, great.
Yeah.
Hi, John.
Okay, you're back. Harshad, how you doing today? I just saw you. Wow.
How are you?
Good. Yeah, we're doing number 2.
Number 2, yeah. Chinese was good.
Abby or Harshad, who wants to host?
Dr. Parekh is going to host it. Let him host it.
Oh, I'm sorry. Who's gonna host?
Dr. Arshad Parekh.
No issues. I'll be there.
Okay. Can you host, Dr. Park?
Yeah.
Okay. Yeah, you know how to keep it flowing.
Yeah.
Some of the questions I don't understand, so it's hard to keep it flowing. You can't pull in the relevant people. Yeah, I'm gonna write Dr. Morcos. We're waiting for Atul. Oh, okay. Okay, we're waiting for Dr. Goel to reboot. Yeah, that's when you change computers. Okay, we're still waiting for Atul to come back in. He's reinstalling Zoom, where sometimes if you have a problem with Zoom, it's better just to reload it. Reload it, put a new up-to-date version of Zoom. Which I think Atul is doing now. Hopefully. Hello, Nargiza, are you there? Nargiza Satova,
Yes, good evening. I'm here. Hello.
how are you doing today?
I'm okay. I'm fine.
Okay, have you met Harshad Parekh from Mumbai, India?
Yes,
I
we
think,
met
yeah,
recently on
last webinar.
Jordan rounds.
Jordan rounds. Yeah.
Good evening, sir.
Yeah, Harshad is going to host today. Okay,
Oh, okay.
and you met Abby Shah. You know, Harshad, Nargiza is going to do some Russian webinars.
Wow, wonderful.
Yeah, we are trying to open Russian neurosurgical grant rounds. So let's
Oh,
hope
wow.
it will work.
Хорошо,
you.
хорошо, посмотрим.
Oh my
Great.
God, Martin, you've been all over the world.
Yes, yes.
You've
Get
been to
Al
Russia
Sufyan.
too?
Who doesn't know Russian? You know what kind of a European is he? You know. Anyway, yeah.
John, can you still give me 5 minutes? There is some still issue with the computer, okay?
Yeah, sure.
Yeah.
Sure. Okay, yeah, that's a
Get
problem
Al Sufyano.
when you change
So,
computers.
so where do you work, Nagisa? Where is your area of?
I have done my residency in Russia, in Novosibirsk, so Siberian part
Okay,
of Russia.
okay.
And then I moved to India, and I have been staying in India for almost 3 years with Professor Aycherian. And now I'm doing my pediatric neurosurgical fellowship in Istanbul. So in January, I will come back to India.
Wow. But you are originally from Siberia.
No, I'm from Uzbekistan.
Are you Uzbek?
Yes.
Okay.
When I was 17, I moved to Russia. I have done my MD and residency. But you know, in Russia, residency just 2 years, unfortunately. So I decided to go further and do my
Excellent.
fellowship.
Kandaysen.
Yaxshi rahmat. So you know all languages.
Little
Family.
bit only a little.
It's great.
And which clinic you are in Istanbul?
Acibadem Hastanesi.
Acibadem.
Yes, it's
This is on the Asian side.
Asian side, yes.
Yes.
They have different branches. I think 2 or 3 branches in Asian and 1 in European side. But
Okay.
I'm in the one which is in Altunizade metro station, so it's quite big. So they have neurosurgical department.
And they have enough children there for sure.
Yes, because per day we do have around 2-3 cases, so it's more than enough. So I'm here for 6 months. In December,
Okay. After 2 weeks, I will be in Istanbul for a short while.
Oh,
Yes.
great.
Yes. Yeah.
You have a conference workshop there?
No, it's for personal reason. And then after I will go, my home country is actually Switzerland. So I will go to see some family, but I will stay in Istanbul. I always stay in Istanbul. I like it.
Oh, great. If
So
I would
for
be
you,
happy to meet you. So if you get some time.
okay. Хорошо. Посмотрим.
So right
Martin,
now
you are in which hospital?
I am in Rashid Hospital.
Rashid, Dubai.
Yeah. And now I branched out to Al Sara, and this is a private hospital. But we will see what will happen. I'm not sure what will happen. So we are also now starting to do some activity for the young people in this Mohammed bin Rashid University. It's all very young, you know. But mostly they have medical students, so it's not really. Yeah, I mean, we did a dissection, cadaveric dissection course last week, and for the trainees, but there are only 2 trainees. There was one from Saudi as well, So not all countries are blessed with a large population like India and Pakistan and China. So you are in Mumbai, are you?
I'm in Mumbai. Yeah,
Yes.
I'm in Mumbai. Yes.
I've
Since many years.
I've always wanted to come over. It's so it's very close, but somehow I find it is ridiculous to go to India just for a short while. If I want to go, I would like to see some of India and like that. So and I haven't really taken the time to do just that.
It's such a big country.
Oh
Very big
yes,
country.
it's a continent. It's a continent. It's like people from the USA, we go to Europe. Well, what do you mean by that? 25 different countries or something, right? Or India, how many states you have? 25 also or something?
I don't know if it's 20. I think there's more than 25.
There's a lot of states. There's a lot
States, lot of states too.
Yeah, 28. Okay.
Yeah, 28 states. Different states are there. Large area is there. Yeah.
Yes, and then there's
And-
Bangladesh, Sri Lanka, and Pakistan, which are culturally also kind of near, kind
India.
of related. Yes, yes.
You know, I told an Indian neurosurgeon, I said, I have a hard time understanding neurosurgeons from Mumbai. He
Yes.
said, well, everyone does because they speak with accents. I didn't realize that. I know in the United States, you guys, have you heard the Southern accent that we have?
Yeah,
It's
yeah.
like a different language. It's so difficult for some people
It
to
is.
understand,
Mm.
but it's English.
It is. It is. You all, what they say. Yes. So such is the world.
Atul has joined.
Oh, good.
Ah,
See,
okay.
where is he here? Yeah. Oh, okay.
No, Harshad, if I come to Mumbai for sure, I would love to
Atul's
come
here.
and visit you,
Yes, yes,
Any-
sure. Please do
Yeah,
come.
yeah.
Okay,
Okay.
It will be
Atul, are you
pleasure.
here?
Yes.
Are you here, Atul? I'm sorry to interrupt. Have you got your sound there going, Atul? Because you're in the panel. I see that. But your microphone is not turned on.
No, Atul should be at the top somehow.
Oh, okay, you're turned on, Atul. You should be able to speak.
Okay.
You know what, John, my problem is there is no share screen on this computer.
Oh. Welcome, Atul. We were
Thank
waiting for you, the guru
Yeah,
of the
yeah.
gurus.
Thank you. I'm having some problem with my computer, but I
Oh,
just,
tell me.
Are you ready to start, Atul?
John, I can open the computer only. Open my, I cannot share the screen. There is no sharing screen button here. Can you see the thing or no? John, are you there?
Yeah, you ready to start?
No, but I cannot share the screen, John, in this.
Atul, can I suggest you something?
Huh?
Why don't you email that whole lecture to Abhida and later share the screen and you give a talk, one by one slides.
It's a very huge thing. There are videos and all in this.
Yeah, it will go.
No, is there any, because I don't know why there is no share button on this computer screen now.
Yeah, you can send Abby the PowerPoint if you want, and she can share it.
Let me see.
Does that sound good, Abby?
That should be good, John. Only thing is the file will be big.
Yeah, I agree. To send this with email, it is a headache. It's too big, no? It have to be. So why is there no button to share screen? It should be.
There's still no button there, still?
There is no button, no share screen information.
You know, are you from a different university? You televising from a different place?
I am televising from a brand new computer. I got it today for this show.
Oh,
All
okay.
right.
So the only solution is to send the PowerPoint to Abby or me. You can try to send it to this address, Atul. I'm gonna give you one. It should. We'll get it. Okay, that's my email.
John, you know,
It's not in this meeting. What? Okay.
But
Try sending
guys,
try sending the PowerPoint to that email address, Atul.
but the sharing of the screen is something that the Zoom application does. So did he?
Yeah, but he
would
doesn't
he
have
maybe?
Doesn't have it. He doesn't have the option.
Sir, can you try this on the Zoom screen? Just click on your Zoom screen. On the left-hand top side, there is something called Zoom US near the Apple icon. Click on that, go to preferences.
Yeah, if there's no share screen, the only solution is sending the PowerPoint to somebody.
John, may I just give a lecture like that without any slides? You think it's okay?
Well, or if you log in again, log out and try again. If Zoom maybe.
No, you just downloaded a Zoom, right, Atul?
Just now.
Okay, you downloaded it, right? Okay, yeah,
Yeah.
it should, I
should
can
be.
understand why. Maybe the hospital has a restriction on Zoom, wherever you're at, that you don't normally have. You know what I'm saying? So I think the only solution is giving us your PowerPoint file. You can try my email address to send the whole file. I know it's a large file, right?
It's a huge file. I got some videos and all. It will be tremendous. What do you think we should do, John?
Is there a tech there? Is there a tech in the hospital? Is there?
What I'll do, I'm not in the hospital, I'm at home. What I'll do is, maybe.
And you reboot it and you put a new file, new Zoom in.
Maybe reactivate, go out of Zoom and reactivate, because share
John,
screen.
I will ask you.
Share screen is there.
Abhida, can you give a lecture on, I will maybe intermittently stop you. You have some slides, you just run those slides, I will, from your computer, can you do that?
Yes, sir, I'll run the slides from my computer, one of your presentations, and you can talk.
Okay,
Okay,
fine.
let me
Let's
just
do it.
get one presentation, sir. Just give me 2 minutes.
Okay, John, so this may be all right, just give 2 minutes, okay?
Okay, so I start now and just hand it over to you and you direct.
Okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett. We have the honor of hosting who I call the king of Zoom, Atul Goel. And I'm going to let Harshad Parekh give the proper introduction. Good day, Harshad. Harshad, are you there?
Yes, I'm there.
Okay, there you go.
Yes, it's my privilege, and I'm delighted and excited also to introduce my good friend, Professor Atul Goel. If you don't know him, you don't know neurosurgery. You are not a neurosurgeon. So his introduction is whole encyclopedia. And what we need is just, he is the one person who makes us to think. And he makes us to understand the whole revolution of the spine. And he's giving a series of lectures to us and giving a new thought to the spinal surgery treatment. Atul, you are the one who can bring really revolution in the spine. So we are awaiting your talk. Floor is yours.
Thank you.
Looking
Thank
for.
you.
Please start.
Thank you,
Thank you.
Harshad. And there has been, I must tell you that there has been some problem with my computer, and I had.
Oh, we're losing your voice there.
Lost the voice.
Atul, can you hear me? We can't hear you. Oh, Lord. Can you hear me, Atul? Or we're not getting the voice.
No, we are not hearing.
It looks like your microphone's not even connected. It's not connected. It's open, but it's, I don't know what's going on. It appears okay on the panel. This is like neurosurgery when things don't go right. You gotta figure out a way to get around the problem.
But John, don't you think if he kind of rebooted the whole thing,
Yeah, rebooting is always a good option.
reboot the whole thing, and just
Atul,
go out for 5 minutes and
try
reboot.
that again, Atul. Can we reboot again, Atul? Because it's still not working well. So can we try that to completely reboot? Okay, good. He's trying it.
Okay.
So yeah, Martin, sometimes that works. You don't know why, but
Yeah, IT has gotten into so many layers. I don't even think I don't think that like companies like Microsoft, they don't really understand what Windows is doing. It's one layer over another layer over another patch over, and sometimes just reboot and that will do.
I know. I tell people that, and when things work, they said, "Boy, Dr. Brennan knows Zoom." No, I just know reboot.
Exactly. Just reset everything to default. That's why we had this discussion about AI, which is a wonderful thing, but I don't believe we will get truly new knowledge out of it.
Yeah.
We will get a lot of mixed things, which we will get really hard to tell what is true and what is not. It'll get even harder than it already is.
Yeah.
Because it will write you a paper that sounds reasonable with references and everything, but you don't know. You really don't know. Anyhow.
I think there's going to be a period of adjustment.
Yes. Okay.
And verification of a lot of things.
Yes. Yeah.
It's going to be a period.
Yeah.
Where you really have to, keep a critical eye on what you hear about AI generated knowledge about neurosurgery.
Yes. Anyhow, it's kind of a sophisticated spell checker, if you like. maybe not a nice way of saying it.
There are some tasks. I use it for tasks.
Yes, then
if
it's
you wanna
fine,
find
you
the-
know, it's fine, works fine, you know, gives you a little phrase here and there, and yeah.
Yeah, it's an alternative source. It's a source, but
Yeah,
not the
okay,
final.
but you have to look at it and decide, does this make sense, yes or no?
Yeah, you have to oversee it. You have to
Yeah,
oversee
you have
it.
to edit it, you have to. Anyhow, I hope it will solve all the problems of the stock market in New York City.
That's the other side of the coin. It can do some damage.
Yeah.
And I don't think we've seen the damage that it can cause once the hackers learn certain programs.
Once they utilize it, you know, to hack. How's that gonna work?
Yeah, it's a tool, powerful tool.
Somebody's connecting to audio. Is it
Oh,
Atul?
okay, Tool's
He
here.
is back. He's back.
Okay,
Okay, let me
Tool,
switch
you're
off.
back.
John, I don't think this is from the phone. I want Dr. Abida to present, and I will just hear, and maybe I give one comment here and there. Just
Okay.
okay.
Okay, that sounds good.
Sir,
Okay.
I have the presentation. You can present straight. See, it's
No.
here on the screen.
So then you, in the
You
meantime,
can talk. Yeah, I will change the slides. You talk.
No, I want to present from my computer. Just a minute. Let me see. This is mobile. Can you hear my voice?
Yes, we can hear.
Okay.
Yeah.
So, John, I'm sorry, I'm giving this old presentation to you.
Okay.
And I was very excited to make several new slides and present a new version of my presentation. Many of you have heard this lecture, and many of you have heard my concepts on this subject. And I have to only tell you that I like to repeat my presentation again and again because I'm so enthusiastic about it. I have a feeling that this is a complete revolution in the subject of spine, and it is a game changer in the subject of spine. I want to introduce to you and to all those who are attending this lecture an absolutely brand new concept in spine surgery. The concept is compression is never the issue, and decompression is never the treatment. Compression is always secondary. Compression is always protective, and compression is always reversible. Compression Hello?
Yes, we can hear.
Yeah, just a minute. I have lost it here now. Yeah, yeah, John. Yeah.
Yes.
So compression is not the issue. Compression indicates that the spine is unstable. And compression indicates that there is a need for stabilization. So compression is not the issue. It is indicator of an unstable spine, and that's it. And also, even if there is no compression in the spine, on radiology, on MRI or CT scan, even in those conditions, there can be an unstable spine, and stabilization is the treatment. So instability has to be diagnosed on the basis of radiological features and on the basis of clinical features, and stabilization is the treatment. Next slide. So movements are very important. Movements form the basis of life. Life is movement. Whenever there is life, movement is there. Next. No, you keep on moving. So the human, you have seen, many of you, most of you have seen these slides, so I'm sorry that I'm repeating these slides. But human body is different. Human structure is different from animals. We are not four-legged animals. We are two-legged animals. We stand, we sit, and we run on two legs. And the entire weight bearing of our weight bearing is managed by the extensor muscles on the back of our spine. And when these muscles become weak, there can be instability of the spine. On the other hand, in a four-legged animal like a horse, there is not too much weight bearing on the spine. It is on the shoulders. It is on the hip joint. In a bird, it is on the shoulders. But in the human body, it is on the spine. And the muscles of the back of the spine are in question. And when these muscles become weak, there is an entity called vertical spinal instability. Vertical spinal instability forms the basis of spinal degenerative disease. It is telescoping of the spine. When there is a weakness of the muscles, there is a listhesis of the facets, or there is a telescoping of the spine. And this telescoping forms the basis of spinal spondylotic disease. All the muscles are focused on the facets, and the facetal, when these muscles become weak, there is listhesis at the facets. Okay, next slide. My feeling is, John.
Yes.
I think there is some overlapping and it is becoming a little difficult for me to present. And I will ask Dr. Abida to present my material. I will give you my presentation in the next lecture. Okay, John? And
Yes,
tomorrow,
sounds good.
Tomorrow there is a live surgical Zoom meeting, which I want to relay the surgery from 8 a.m. tomorrow. And I hope that several people whoever are watching can join the live surgical videos, which will be relayed from the operation theater. So Dr. Abida, you please go on and keep on presenting, okay?
Yes, sir. Should I just continue with this presentation?
No, this is a whole.
Hello? John, just give me a minute, okay? I'll get some other presentation. Just give me a minute.
Take your time. My face in chocolate.
John, what happened?
We're waiting for Abby to get it together, her presentation.
Oh, I also,
Continue on with,
yeah.
John?
Yes, okay, Abby.
Yeah, so I'll present another topic on craniovertebral junction. Is that okay?
Oh, that's fine.
Yeah. Can you see
Yes.
my screen?
You can see it. You want presentation mode? There we go. Perfect. Okay.
Okay. So I'll just present this topic. I hope this is fine. So this is challenges, perspective, and future of the treatment of basilar invaginations. So it is a little bit of an historical topic with the current understanding and paradigm shift in basilar invagination. Okay, so the first accounts of basilar invagination were actually when Ackermann noticed this condition in cretins, and it was seen at the first time there in them, and then Retzius and Berg actually classified it and called it impressio basios crani. This was why, because they found an impression of the base of the skull on the prolapsing into the cranial cavity, and that's why they called it this. Later, it was called as platypasia by Furkow, and at that time, it was thought that basilar invagination and platypasia are the same thing, and both the terms were used interchangeably for a long time. It was only later that there was a difference noticed in both of them. Platypasia was called as an abnormal flattening of the base of the skull, as you see here. You know, these lines, the basilar angle, the clivocanal angle is very obtuse, and there is an abnormal flattening of the base of the skull. And basilar invagination was basically defined as prolapse of the vertebral column into the skull base, as you can see here. So the odontoid has crossed this Wackenham's line and gone and prolapsed into the skull base. And this was called as basilar invagination. This is a very historical drawing, and this is how it looked. You know, when the spinal cord prolapsed into the skull base, it kind of made an impression into the base of the skull, and this was called as basilar impression. And this is how it looked on a post-mortem specimen. So these things, this basilar invagination remained a radiological entity and an anatomical curiosity, and the treatment of this entity was not known. If you see this paper by Chamberlain, it says, it is as though the weight of the head has caused the ears to approach the shoulders, while the cervical spine, refusing to be shortened, has pushed the floor of the posterior fossa upward into the brain space. And that is how we defined basilar impression. So even though it was first diagnosed in 1911, for a long time, as I said, this remained anatomical and radiological curiosities. You even see this line, the American literature is singularly lacking in reference to basilar impression, though a few references have been made to somewhat related type of anomalous development at a lower level in the cervical spine, the so-called Klippel-Feil syndrome. So what happened in the earlier times when Chamberlain started the first treatment for basilar impression? He had two patients in which he did suboccipital decompression with upper cervical laminectomy. One patient survived this surgery but did not improve too much, whereas the other patient died. So the morbidity and the mortality of this treatment remained high. But at that time, even the treatment was exclusively surgical, and this is what they used to do, suboccipital decompression with an upper cervical laminectomy. As you can see, the results were variable and the associated morbidity and morbidity remained high. So the journey of craniovertebral junction treatment anomalies actually started in Mumbai, actually started in our hospital, the KEM hospital in Mumbai. So you can read this. This was a paper by Dr. Bharucha and Dastur, where they said that craniovertebral anomalies have only recently gained in popularity and its value is yet to be fully assessed. So while treating these anomalies, Professor Goel in 1987 first described this technique when he was still a resident in neurosurgery. He described this technique for plate and screw fixation of the atlantoaxial joint, as you have seen in all his publications. And the treatment he used was, I'm diverting a bit from basilar invagination to show you the genesis of the treatment that came into picture. So the treatment that was used was an opening of the joint, the denuding of the articular cartilage, stuffing of the joint with bone chips, and then insertion of screws in the C1 and the C2 joint and fixing it with plate and screws. As you can see this image, this is one of his first patients that he used to do plate and screw fixation. So this technique developed and then slowly gained popularity. So this was in 1998, basilar invagination again was this paper was presented by Professor Goel, and you can see that in that time he had divided basilar invagination into two groups. There was group 1, which was basilar invagination without Chiari formation, and group 2, where basilar invagination had Chiari formation. So this is how we initially divided basilar invagination. And what was the treatment for this form of basilar invagination that was advised? In this group, a transoral surgery with or without posterior fixation was done. And in this group, he had advocated a foramen magnum decompression. So this was still in the year 1998, and this was the treatment that was suggested for this group of abnormalities. Later, as the development and understanding of craniovertebral junction anomalies progressed, it was realized by Professor Goel that atlantoaxial dislocation is never fixed. So at that time, there used to be an entity called mobile and fixed atlantoaxial dislocation. In mobile atlantoaxial dislocation, the atlantodental interval changed on flexion and extension, wherein in fixed atlantoaxial dislocation, the atlantodental interval did not change. And that's why it was called as fixed. In 2005, during this paper, when this paper was presented, during the evolution of that time, Professor Goel realized that the atlantoaxial dislocation is never fixed. It is hypermobile. And when you open the joint and reduce it, you can reduce the atlantoaxial dislocation, and realign the craniovertebral junction. So if you see this image, this is a fixed atlantoaxial dislocation where you see after flexion and extension, there is no change in the atlantodental interval. So this is after surgery when the joints are opened and distracted and bone chips are placed in it and a fixation is performed, and you can see the reduction of atlantoaxial dislocation. This is again another patient with a fixed atlantoaxial dislocation reduced by plate and screw fixation. So there are a lot of examples of fixed atlantoaxial dislocation we can be easily treated by doing a distraction and reduction. So as the understanding of these joints, the understanding of the basilar invagination evolved, Professor Goel then presented this paper, and in that, basilar invagination was divided into group A and group B. And this paper actually revolutionized the treatment of basilar invagination. So you see group A was, earlier we divided it on the basis of Chiari formation. Now in this, the classification was not based on presence or absence of Chiari. It was based on certain lines. So group A was when the odontoid prolapsed into the skull base. It crossed the Wackenheim's clival line, it crossed the Chamberlain's line, and it crossed the McRae's line. So this was group A. And group B was when the odontoid crossed the Chamberlain and the McRae's line, but did not cross the Wackenheim's clival canal line. That was what was called as group B. So at this time now, for group A, the surgery recommended was distraction, reduction, and fixation of the C1, C2 joints. For group B, at this time, we still advocated a foramen magnum decompression. So this treatment, this craniovertebral realignment actually revolutionized the treatment of basilar invagination, and it forms the basis of treatment of this entity at the present time. So as you can see, it was realized, you see all these images, look at all these joints. So you see the C1 joint here and the C2 joint here. See the varying alignment of these joints. So the joints are abnormally inclined. They are not fixed. They are completely mechanically unstable. They are mobile or hypermobile. And you can create a reduction by opening the joints, inserting bone graft into it, and fixing the C1, C2 region. So basically, it was realized that basilar invagination is a disease of the atlantoaxial joint. It is a dynamic and progressive process. There is increase of the slippage of atlas over the axis over the period of time as the patient grows. And this process of slippage may be exacerbated by trauma. So this was a paper written by Professor Goel and Dr. Kothari, where they likened the atlantoaxial instability of basilar invagination to a lumbar spondylolisthesis. As you can see here, the L5 has prolapsed over the L of the S1. The same thing was called a transatlantic odonto-occipital listhesis, the so-called basilar invagination. And this made the cover page of Journal of Neurosurgery Spine in the year 2005. So now you see, I'm going to show you some examples of this treatment where you have to just go in, open the joint, insert bone chips, and then put a screw in C1 and put a screw in C2. Earlier, we used to use a lot of spacers to reduce the basilar invagination, but the indications of spacers has gone down, and we are inserting bone chips into the majority of the times we are inserting just bone graft into the C1, C2 joint. So you see this patient with a group A basilar invagination. This is the distraction and reduction of the joints, and you can see the C1, the craniovertebral realignment. This again, another patient with basilar invagination. You can see where the odontite has prolapsed inside the skull. And now you can see that after the surgery, it has been realigned. And this is the plate and screw fixation of the C1, C2 region. This again, another patient with basilar invagination. You see the joints, you see how abnormally inclined the joints are. It is very difficult to open these joints during surgery, but you have to learn it. And if you can do this, you can get this kind of result where you can actually bring down the whole odontoid and realign the craniovertebral junction. So this is again another patient with basilar invagination where the joints are abnormally inclined. And what is the surgery? Opening the joint, putting bone graft into it, and performing a C1, C2 fixation. So we have a host of cases, different kinds of anomalies with these kind of patients, which we are treating on a day-to-day basis. Here you can see the abnormal configuration. So we sometimes use 3D models to understand this configuration, and it really helps us during the surgery. So here you can see another basilar invagination with the abnormal joints fixed by doing a C1, C2 fixation. Over the period of time, Professor Goel has also realized that it is not just realignment that is important, it is the stability that is more important. So you can try to reduce the joint as much as you can, but a good fixation will serve the purpose better, even if you cannot completely realign the craniovertebral junction. So this is again another patient with basilar invagination treated by C1, C2 fixation. So you can see this patient did very well following the surgery. So we have a lot of examples now. So you see this patient with a group A basilar invagination with Chiari and with a syrinx. And you can see after the fixation, the Chiari has gone up and the syrinx has almost disappeared. So this is the kind of result that you can expect. So this is another patient with basilar invagination and a syringomyelia. This patient also has an external syringomyelia. You see the amount of fluid in the front of the cord, in front of the brainstem here, which we call as external syringobulbia. You can see also that there is a component of vertical instability here. You see in flexion, the odontoid is going up. In extension, the odontoid is coming down a little. This is the abnormal inclination of the joint, and this is the fixation and the realignment after surgery. Again, another patient, and you can see how beautifully it has been realigned. So the trick is going in, opening the joints, and performing a good, stable C1, C2 fixation. This can be done by putting bone chips, because that is what is going to hold the region after the implants in a period of 3 months. So this is again another patient with basilar invagination with the fixation. So these are a lot of patients that we have done, and I'm just going to quickly run through it. Otherwise, I will just keep showing images. So as we were treating these patients, we realized that a lot of musculoskeletal changes that occur in basilar invagination actually reverse after this procedure of C1, C2 fixation, distraction, and reduction. So the torticollis reverses in the immediate postoperative period. You see the short neck of this patient that has also become long. All these changes were observed in the immediate postoperative patient. And you also see that the neural abnormalities reverse. So the Chiari goes up and the syringomyelia reduces. This is within 48 hours of surgery. And you can see how the syrinx has already started reducing in size. So this is again another patient that I showed earlier. Here you see the reduction in the Chiari and the syrinx. So this was our experience with 510 cases, which we published some time back. As I said, we use 3-dimensional models. So you see the difference. So this is a 3-dimensional reconstructed CT scan image, whereas this is a 3D model. So here you can see the anatomy clearly. You can see the vertebral arteries actually got in an abnormal course here. It is running over the C1 facet. So this gives you a very clear view of the anatomy of the region. So it is a good, in complex cases, it is good to have these 3D models. They are very helpful. This is again another patient in this patient, we actually did a C1, C2 fixation on one side, and on the other side, we actually put a spacer because of the abnormal course of the vertebral artery. So you see another 3D model where again, the vertebral artery is going on the C1 lateral mass. So you have to be aware of these abnormalities when you're treating these patients. This is again another patient where you see again on one side, we have done C1, C2, and on the other side, we have put a spacer. This is another patient with a 3D model. Here you can see that the vertebral artery, there is no C1 and the vertebral artery is directly entering into the cranial cavity from here. And here we actually did a C1 and a C2, 3 fixation and got stability of the region. So while doing this C1, C2 fixation, there are many combinations and permutations of fixation things that you can do if you run into trouble. For example, if you have an abnormal vertebral artery, or if you have some, if there is a problem in the pedicle of C2, or it is a very thin pedicle, or you're having problems in maneuvering the vertebral artery, then there are many other variations of the technique that you can perform, and we have published. So this is a caudally directed inferior fixation where you fix this, go into the inferior facet of C2 and do the fixation, where you can, in some cases, you can just use a spacer as a standalone method, and we've called it atlantoaxial joint jamming. This is a double insurance. On one side, C1 for the C1 lateral mass screw is there. On C2, the screw takes both C2 and the C1. So it is a variation of the Magarel's technique, and this is actually a double insurance atlantoaxial fixation. In some cases, when there is a very high basilar invagination, you might need a transcranial insertion of the atlas screw, where you have to perform a small craniectomy in the region of the occipital condyle and C1 lateral mass, and then insert the screw. So this is the joint that is most important, the C1, C2 joint, and understanding of this anatomy of this magnificent C1, C2 joint is the key while performing surgery in this region. So this is basically everything revolves around these joints. A little bit about the anatomy. I think Professor Goel has already shown this earlier, but I will just show you quickly. So this is the superior facet of C1, which articulates with the occipital condyle, and this is the inferior facet of C1. This is the C2, where you see the superior and the inferior facet are not in line, are not lying one above the other like in the subaxial spine, but are actually lying, they have the intervening pars interarticularis between them, and they're lying one in front of each other. The superior facet of the C2 actually houses a part of the vertebral artery. As you can see here, this is the anterior view, and sometimes the vertebral artery actually makes a notch here, and you call it a high riding vertebral artery. So as the understanding of craniovertebral junction and basilar invagination evolved, this was the new classification proposed by us. And here you've heard this before. So this is type 1 atlantoaxial instability, where the facet of axis is in front of the facet of atlas is in front of the facet of axis. This is generally seen in atlantoaxial group A cases of basilar invagination. So this is a patient with group B basilar invagination, and you see this, the facet of atlas is actually going behind the facet of axis, and this is type 2 atlantoaxial facetal instability. And this is the third type where actually the facets, this is also type 2, where the facet of atlas is going behind the facet of axis. And the third type is when the facet of atlas and axis are both in alignment, and there is no demonstrable radiological instability seen on the scan. So this entity, where you cannot see a demonstrable radiological instability, we have called a central atlantoaxial instability. And the concept is that even though you cannot see it, there is an evidence of atlantoaxial instability, and you realize this by having some markers and also intraoperatively. So as our understanding of basilar invagination has improved, we have realized that not only group A, but group B is also due to mechanical instability, and atlantoaxial fixation for basilar invagination group B is also the treatment of choice. So you see this patient here, you see this is flexion, this is extension. There is no change in the atlantoaxial instability, atlantodental interval. You see the facets. There is no evidence of any malalignment in these facets. This patient has a Chiari and a syrinx. We have done, you see the basilar invagination. You see, even though it is not crossing the Wackenheim's line, it is crossing the Chamberlain's and the Macrae's line. And we've done a C1C2 fixation. And this is at the end of 3 months of surgery, where you see the Chiari has improved, the syrinx has gone down. So we've realized that even for group B basilar invagination, the treatment is atlantoaxial instability. And this is based on a huge number of cases that we have treated. And you see again this patient where we also had a 3D model. So you see how complex this is. The occiput is actually touching the C2. It is very difficult to expose this region, but if you learn how to do it, you will be able to give a gratifying result to this patient. And you can see the atlantoaxial fixation done with it without any kind of decompression. There's another patient with a Chiari and a syrinx and a group B basilar invagination with some type 2 atlantoaxial instability. And this is after surgery of C1C2 fixation, where you see the Chiari has reduced and the syrinx has reduced. So there are many cases now that we have. So you see this patient, the Chiari is absolutely gone back. The syrinx has reduced to a thin streak. And what have we done? Just a C1C2 fixation, no kind of decompression. So instability is the cause of basilar invagination, whether it is group A, whether it is group B, and C1C2 is the fixation for this. So this is the evolution of the treatment of basilar invagination, where first there was an era of decompression, as you saw by Chamberlain. Then we also recommended an era of decompression and fixation, where, for one group, we used to do transoral decompression followed by fixation. In one, we used to do just a foramen magnum decompression. And then we moved to this era of craniovertebral realignment and only stabilization. And now we are in the era of only stabilization, even for cases of group B basilar invagination. Just a minute, John. So transoral surgery has been pushed into the realms of history, and we hardly ever find any indication of doing transoral surgery. So now, as more we got into this treatment business of understanding of the pathology and pathogenesis of craniovertebral junction, we realized that even in Chiari formation, atlantoaxial instability is the cause, and atlantoaxial stabilization is the treatment. And this is a recent experience with 388 cases of Chiari formation, where we have treated the patients with just C1C2 fixation. So this is an example. Here you see that there is no basilar invagination. There is a type 2 atlantoaxial facetal instability. And this is after the fixation. You see the syrinx has gone and the Chiari has reduced. This is again another patient with no basilar invagination, just Chiari. There is no other problem in the craniovertebral junction. There is just a Chiari and a syringomyelia. You see the type 2 instability. You see we have just done a C1C2 fixation without any decompression. You see this beautiful image where the Chiari has gone up and the syrinx has reduced. This is again another patient with only Chiari, basilar invagination, no basilar invagination. And you see the syrinx has reduced and the Chiari is also better. There are a lot of examples. So you just see there is no basilar invagination. There is no craniovertebral bone anomaly. There is just a Chiari and a syrinx. This is the neural manifestation of atlantoaxial instability. This is a mild type 2 facetal instability. What we have done is just C1C2 fixation, and you see the result. And more than the radiological result, it is the clinical outcome. The patient improves in the immediate post-operative period. And we have so many examples. Professor Goel was going to show you many videos. He has shown you, I think, already of craniovertebral junction, but also in spine, which he will show you at a later date. Is again another patient with Chiari and syringomyelia. This is the type 2 facetal instability, and this is the C1C2 fixation. You see the Chiari is almost reversed, and the syrinx has also reduced dramatically. So there are a lot of examples. You see this one, the syrinx has actually gone, practically gone. The Chiari has gone back. So there is no doubt at all that the instability is the cause of Chiari, and atlantoaxial fixation is the treatment. So there were a lot of papers when we published this. There were a lot of letter to editors saying that, it might not work in the pediatric age group. So we published this paper where we had an experience with 33 patients. There were also a lot of papers that said that it works only for craniovertebral junction anomalies and not in patients without any bone abnormalities. And this is our experience where we did fixation for patients with only Chiari and syrinx and no craniovertebral bone anomaly. And these were our results. Even in patients who failed foramen magnum decompression, if these patients, if they come to you, what are you going to do? You cannot keep on removing the bone and opening the dura and removing the tonsils. You have to do a C1C2 fixation. So there are a lot of our patients we had earlier done, in the 90s, in the late 80s, which were treated by foramen magnum decompression, are coming back to us, and we are doing a C1, C2 fixation, and the patients have improved following that. So this is again another patient who had undergone a decompression, a shunt insertion, and this patient came to us. She had worsened significantly after the surgery. Not only they don't, for a transitory period, they improve, but over the long run, these patients ultimately deteriorate. And we are seeing now that they're coming back to us, and we do a fixation, and the patient has improved after surgery. So this was our paper on the subject of failed foramen magnum decompression in patients for Chiari formation. So even while we were, studying this subject, we realized that, we did monitoring in a few cases with just Chiari with syrinx, with patients with group B basilar invagination. And we monitored the transcranial MEPs before the surgery and after the insertion of screws. So it was it was really great to see that just after tightening the screws on both sides, there was a 30 to 40% improved in the MEPs, as you can see in this image. You see this image and you see this image. There is a definite improvement seen in these MEPs. So there is no doubt at all that C1, C2 fixation is the treatment for these anomalies. Again, another patient where you see the MEPs have improved. You can see these lines in the immediate during surgery, intraoperatively after tightening of the screws. So this was our paper on this subject. So basically, what we have to say is basilar invagination, syringomyelia, and Chiari are a spectrum of abnormalities or anomalies or alterations whose main problem is atlantoaxial instability, and that is what you should treat. You should do C1, C2 fixation and not any kind of decompression. Extrapolated to this, there are many patients who present to you with idiopathic syrinx. They have classical presentation of craniovertebral junction anomalies clinically. They have a spastic quadriparesis and all the other classical signs. And sometimes you don't see any other abnormality. In these patients where you have no other cause, you've ruled out all other cause of syringomyelia, sometimes it is just the atlantoaxial joint that is the problem, and subtle atlantoaxial instability can be the problem. You treat it with the C1, C2 fixation, and you see this, the patient recovers clinically immediately, and radiologically, the syrinx disappears after a period of time. So this is again another patient. All you have, this is the type 2 fascial instability. We've done a fixation, and you see the syrinx has already started disappearing. Again, another patient. This patient just came to me 15 days back, and the syrinx has actually gone. I wasn't able to put this image here, and she's clinically absolutely fine, back to her routine life. So basically, basilar invagination, syringomyelia, and Chiari are a spectrum. Atlantoaxial instability is the cause, and these are actually nature's protective formations to stall and delay the effects of instability. Chiari is also, we have changed the terminology. We no longer call it a Chiari malformation, we call it a Chiari formation, because, it's like an airbag that comes in to protect in the, when you have a crash. So based on this, Dr. Goel says that can foramen magnum decompression surgery become historical? And I'm quite convinced that it is going to become historical in a little while. And now this is a recent paper on the subject. We've just published it. A new entity of central or axial atlantoaxial dislocation. And all those who are interested can read the paper. As the understanding of basilar invaginations has evolved, it appears that mechanical instability is the cause, and craniovertebral realignment, and may I correct it, craniovertebral stabilization is the current management of this anomaly. Thank you very much. Just to conclude, the atlantoaxial stabilization is the treatment. Occipital fixation is not necessary. Foramen magnum decompression is counterproductive, and transoral, transnasal decompressive surgery are historical in our realm. Thank you very much.
Okay, thank you, Abby. Harshad or Atul, do you want to moderate?
John,
Go ahead, Atul.
now I can share my screen.
Oh, God, great.
There is a share screen button now. And if you want, I can little bit, maybe few slides I can show, okay?
Show as much as you want.
Okay. Wait. Just a minute, John. In the meantime, John, you can keep on discussing. Let me just
Abida, excellent talk, excellent talk.
Thank you, Dr. Martin.
Dr. Atul is blessed to have a student like you. Not many of us do.
I'm even more blessed to have a teacher like him.
Abida, you were the extension of hands of Atul Goel just now. You were talking as if we hear Atul is talking.
My wife has done this setting up, and let me see if I can set it up somehow. I don't know, some problem is still there. But you can go on, Harshad, please.
No, she's presented your thoughts, completely summarize everything. I've been following you since 1987, and you have revolutionized this treatment of whole craniovertebral junction, and now you are giving a new thought to the spine.
I
And
want to.
Yes, Atul.
No, still there is some issue. I cannot. Just a minute.
All can wait, Atul, for you.
Well, yes.
I'm not.
Except, guys, I don't want to be rude, and I'd love to hear of this. And why don't you, really make it a proper long presentation? I have a meeting at 8 o'clock, so it's
Okay,
not
John,
20 to end. But
John, let us do it some other time. Maybe better to give a long, full presentation.
yes,
I want my friend to be here.
yes,
Completely, Martin.
yes.
And without you, this.
Well, we could do it next Sunday if you want. Well, think about it.
Yeah, we'll think about it.
Okay, John will announce it.
Okay, so let's do it in a big way, in a proper way next time.
Yes.
And let us not be half-hearted here and half-hearted there. Let us work fully, and let me just see if we can get a proper thing. Any case, John, thank you very much, my dear John. And
Well, let's see if we have some questions here for Abby's talk. Okay.
Okay.
Anybody have any comments on Abby's talk?
Yeah.
Martin, do you have something to say?
Well, it just makes sense from A to Z, and I've been sort of vaguely following the discussion also since being a resident. And when you look at all the theories they had about Chiari malformation, which is more frequent than this platybasia stuff, but there was never really a good explanation for it. There were all these hindbrain sort of, already embryonic, but this kind of long-term, slow occurring dislocation instability then leads to abnormality in the CSF circulation around the foramen magnum, and then opens up the central canal. And it just makes sense from A to Z, and they are proving it. It's not only some concept, it's actually, they show us the cases, so why don't we believe it? Okay, enough.
Martin, the treatment has already been established by most of the neurosurgeons all over the world.
Yes.
About C1, C2. There
Yes,
is an instability, and we have to fuse and fix it.
Yes.
So what they are saying, we are hardly doing any C1 for transoral surgery nowadays.
Oh no, that one is historic for sure.
So for what in nutshell he is saying, all these things are under one roof. It's C1, C2 instability.
Yes.
And
absolutely.
Arnold Chiari is a protective phenomenon.
I can say for sure, you know what? C1, C2 instability is not just bilateral X-ray and atlantodental interval. C1, C2 instability has a huge number of problems associated. And those problems are not only Chiari malformation, syringomyelia, basilar invagination, kyphoscoliosis, torticollis, C2-3 fusion, C2 bifid, C1 bifid. So many, a range of problems can be secondary to atlantoaxial instability. Atlantoaxial stabilization is the treatment, and any form of decompression. for any of these pathologies is just a negative form of treatment. So basilar invagination, if you do decompression, it is negative. For Chiari, if you do decompression, it is negative. For syringomyelia, if you drain the syringe, it is negative. For kyphoscolio, for clipal file abnormality, even if there is no compression at C1, C2, you should do C1, C2 fixation. When you see C2-3 fusion and no other problem in the spine, it is C1, C2 instability. When you see bifid C1, even if there is no compression and if there are symptoms, it is C1, C2 instability. So C1, C2 instability has huge ramification, and these has to be understood properly, Harshad, as you have seen from so many of my presentations. And this can revolutionize, completely revolutionize, not only craniovertebral junction, but the spine surgery. Like for instance, central instability is also associated with spinal degeneration. You can have multi-segmental spinal degeneration and central instability. You can have OPLL and central atlantoaxial instability. You can have Hirayama disease and central atlantoaxial instability. You can have high C2-3 disc and central instability. So there are so many issues. Harshad, I am so positive about the future of this understanding that there is no question a complete revolution on the subject is here and here to stay.
We accept it, and we follow that. The C1, C2 is the answer for all these problems.
Okay. Yes, Markel was in St. Goel, and so I was familiar in the early 90s with placing a screw through C2, a single screw, and then going into the lateral mass. Now, obviously, Atul has now plates, and it is much stronger. But I will say something when he gives his presentation, my thoughts about it, why all of this is really of enormous importance for the cervical spine, and further down to the cervical thoracic junction as well, which is you're going more into the degenerative disease down there. But anyhow, let me close. I have a meeting in 15 minutes, and I would love to talk to you guys. I want to come to Mumbai tomorrow, but no time right now. Thank you.
Thank you very much. Thank you very much. John, there are some more young fellows on the screen. If you want some comments from Muhammad is there, and I can see Yang Dong from China is there. You want some comments from them?
Yes. Yandong, you want to comment, or anyone else on the panel?
Anthony is there. Yandong, you are on the screen. Go ahead.
Yeah. I'm here. I'm the only one I want to say is I'm really looking forward to tomorrow's lab workshop, and so see you tomorrow, Professor.
Okay, Yangdong. So
Yeah,
tomorrow's workshop. John, are we ready for the workshop tomorrow?
Yeah, let me show you, let me share the screen, Atul, about what we're doing tomorrow. Now, can you see this okay?
Yes.
Oh, man.
Yes, maybe I will try to broadcast this one to all Chinese surgeons.
All right. Okay. I'm sorry, hold on. Okay, I wanted to share the screen there. Just give me a second, and I'll show the link. It's on my Facebook page. All the lectures coming up are on my Facebook page. And I'm going to show you, we're starting, what time are we starting tomorrow, Atul?
This will be 8:30 India time. Or
Okay.
maybe 8:45.
It's 11:30. It's 11:30 Eastern Standard Time on Thursday. Okay, so this is the live tomorrow from 8 o'clock India time to
Yes.
for about 8 hours, I guess.
About 8 hours, yes.
We're going to continually run that for 8 hours. There'll be some commenting, of course. The course is someone, let's see, let me get Abby. Let me show you the speakers. Okay, here's a list of the speakers. Do you see the screen share, Abby?
No,
Okay, let me try again. Okay, here are the screen. Here are the panelists we have. Harshad is going to be on the panel tomorrow. Marcos Wagner, visiting from Brazil. Harshad, Dr. Tripathi. And hopefully all these neurosurgeons will be commenting on Atul's surgery and start discussions while Atul is operating. So what are the cases you're going to do tomorrow, Atul?
tomorrow there will be spinal degeneration. One will be OPLL and myelopathy. One is big syringomyelia. One is pituitary tumor. One is, there are several cases, John, at least 6 or 7 cases. So we start at 8:30. Let us see what all we can do. And it will be continuously relayed on neurosurgical TV.
Great. We'll try to put a list of the cases you're going to do as far as you know. So, okay then. Thank you all for coming, and we'll see you tomorrow at the live surgery lecture.
Thank you. Thank you.
Thanks, everybody.